Hi, everyone. Welcome back to our podcast. Today, we will be covering the brainstem region in Chapter 21 from our textbook, Neuroscience Fundamentals for Rehabilitation by Lori Lundy-Ekman. Today's episode is a really important one because we're not just learning anatomy, we're learning how to use it clinically. We'll divide today's episode into two different parts. We're going to start with a walkthrough of our brainstem anatomy and function, and then we'll shift into some clinical reasoning to learn about the rule of four, a tool for localizing brainstem lesions and syndromes. Let's start with our anatomy. We can zoom out first. Think about where the brainstem is at. It sits between the spinal cord and the cerebrum. It has three parts, the midbrain, pons, and medulla. Functionally, our midbrain is doing a few critical things. It carries motor signals down. It brings sensory signals up. It houses most of our cranial nerve nuclei, and it regulates vital functions like breathing and heart rate. Now let's talk about our organizing principles. The brainstem can generally be divided into a posterior and anterior part. Our anterior part is going to be the basilar, which is mostly motor signals. Posterior part is going to be our tegmentum, which is sensory, cranial nerves, and reticular formation. And this applies across all three levels. When we zoom out into the midbrain, we can add one more layer. We have our anterior part, the basilar part, which is our basis pedunculi, our tegmentum, but then we also have our tectum, which is a special posterior region for reflexes. The organization of the brainstem is what lets you start predicting if you have an anterior lesion, you may have some motor problems, or if you have a posterior lesion, you may have sensory problems, cranial nerve involvement, and consciousness issues. And that's exactly what we're going to build on. Let's talk about the rule of four. This is going to be your clinical shortcut, and it's actually going to get pretty useful. The rule of four is a quick way to memorize and localize brainstem lesions. The first rule is going to be cranial nerves by level. So when you are looking vertically at the brainstem, our midbrain is going to have cranial nerves 3 and 4. Our pons is going to have cranial nerves 5 through 8. And our medulla is going to have cranial nerves 8, 9, 10, and 12. Just as a quick note, cranial nerve 8 goes both into the pons and medulla, and cranial nerve 11 is not in the brainstem, it's in the spinal cord. So if you see a cranial nerve deficit, you already may have a clue about where the lesion is located. Rule number 2 is going to cover the 4 S's. These are our lateral structures. The 4 S's tells you what happens in the lateral brainstem lesion. If our spinal thalamic tract is impacted, we lose sensation of pain and temperature from our body. If our sensory trigeminal is impacted, we lose the sensation of pain and temperature from our face. If spinal cerebellar is impacted, we lose control of coordination. And if our sympathetic pathway is impacted, we lose eye and pupil control. So if any of these are impacted, you're likely in the lateral brainstem. A lateral lesion gives you a classic pattern, including ipsilateral facial pain and temperature loss, contralateral body pain and temperature loss, ataxia, possible Horner syndrome, and cranial nerve deficits depending on the level. This is exactly what you see in lateral medullary syndrome. Rule number 3 is going to talk about motor cranial nerves. Our motor cranial nerves, as a reminder, are cranial nerves 3, 4, 6, and 12. These are midline structures, so they help you identify medial lesions. Rule number 4 is going to be our 4Ms, medial structures. So if we have motor tract involvement, that's going to be our cortical spinal tract. Our medial lemniscus is going to control fine touch and proprioception. Our medial longitudinal fasciculus is going to control eye and head coordination. And our motor nuclei of cranial nerves are located here again. Remember 3, 4, 6, and 12. So medial brainstem lesions may only affect one of the 4Ms. Now that you've got a system, think about this. Our cranial nerves will tell us the level of where it's at, and the letters S versus M will tell you if it's lateral versus medial. So now let's talk about the brainstem dysfunction. Any disruption of vital functions can happen because of brainstem damage. This can include an increase in heart rate due to loss of vagus nerve input, fluctuation of blood pressure, and breathing cessation. That's because the medulla and pons regulate these systems. The four Ds of brainstem dysfunction include dysphagia, dysarthria, diplopia, and dysmetria. Dysphagia is going to be a difficulty in swallowing, and that's going to be because of lesions in cranial nerves 4, 7, 9, 10, or 12. Dysarthria is difficulty with speaking, caused by lesions of cranial nerves 5, 7, 10, or 12. Diplopia is double vision, caused by lesions of cranial nerves 4 or 6. And dysmetria is the inability to control distance of movements caused by lesions of the cerebellar peduncles. So if you see these signs or symptoms, think brainstem involvement. Before we wrap up, I want to add one more layer to this because this is where the brainstem becomes not just important, but critical. Let's talk about consciousness. So what is consciousness? At its core, consciousness is awareness of yourself and awareness of your environment. It exists on a spectrum from fully alert all the way down to coma. But here's a key connection. The brainstem, specifically the reticular formation and ascending reticular activating system, plays a central role in keeping you conscious. Now let's walk through the levels of consciousness. It's on a continuum and it constantly shows up in our clinical settings. We'll start with mild and move towards the most severe. A person that's showing clouding of consciousness is going to have some mild inattention and reduced alertness. Someone in a confusional state may be disoriented and have difficulty following commands. A lethargic person will be very drowsy but still able to be aroused. If someone is obtunded, that means that they have slowed responses and decreased interest in their environment. Someone that's considered being in a stupor requires strong and repeated stimulation to be aroused or to be stimulated. And someone who's in a coma has no awareness, no wakefulness, and cannot be aroused. This progression will help you gauge how severe the dysfunction actually is. Now let's connect this with some pathology. If we have a tumor within the brainstem or the cerebellum, this can lead to an increase in intracranial pressure and can compress the brainstem itself. This extra pressure will lead to headaches, nausea, cranial nerve deficits, and ataxia if the cerebellum is involved. Because the skull is rigid, there's nowhere for the brain to go, so even benign tumors can cause serious damage. With ischemia, our brainstem ischemia can cause sudden dizziness, visual disturbances, weakness in coordination and sensory changes. And vertebrobasilar insufficiency can also cause transient symptoms when the neck is extended or rotated. So position alone can trigger symptoms in the patients. So bringing it all together, if you want to understand the brainstem, you have to understand your anatomy, have a good comprehension of the rule of 4, which helps us look for cranial nerve involvement in ipsilateral versus contralateral patterns. You can ask yourself, is this medial or lateral? And what level is this at if you're looking at lesions? And once you get into doing that, these cases can go from overwhelming to pretty solvable. Thank you guys for listening, and I'll see you next time.